This is Crystal Phend with MedPage Today here in Chicago at the American Heart Association meeting, where I'm speaking with Dr. Robert Harrington of Duke University. So we saw some data come out this morning that proves some of the intuitive assumptions wrong in cardiology. What stood out to you?
So there was a number of exciting things presented at the Heart Association meetings today, and I think, as you've rightly said, we've seen two clinical trials, one done in patients with heart failure testing resynchronization therapy, and one done in patent foraminal valley, PFOs, testing closure of those PFOs. And what we've seen is that our assumption, which seems very logical going into each of the trials, in fact, was not borne out. And so let me expand on that. We saw two trials today. One was the SMART AV trial. And this was a trial that is a little bit technical in how the electrophysiologists think about setting the timing of cardiac resynchronization therapy. To back up a bit, we know that cardiac resynchronization therapy in patients with severe heart failure, class 3, class 4, is associated with better outcomes, better quality of life. And so the electrophysiologists were interested in, can we take that observation and by technically perhaps setting the timing of the resynchronization using either an echocardiographic approach or an algorithmic approach in response to that individual patient versus just a fixed therapy, everybody gets the same AV timing, could we make the procedure better? Quality of life, some of the systolic volumes as measured on echo. So they do a randomized trial, 3-arm trial, and you would think going into the trial, well, that makes a lot of sense. If you're individualizing, that must be better. And in fact, no difference amongst the arms. It does not appear as though there's an advantage in this population, looking at some of the measures they did largely around heart volumes and quality of life, that the smart way of adjusting this was better than just a standard, everyone gets the same. So important lesson, intuition needs to be tested because we're not always right.
And the same was true in
the same was true in the closure trial. So the clinical problem is that there are a group of young people, 40s, 50s, less than 60 years old, who have what's called cryptogenic strokes. They have strokes for which we cannot explain the etiology. They don't have a thrombus in their heart, they don't have a blockage in their carotid artery, something that we can say, that's why they had a stroke or a TIA. Some people who have the so-called cryptogenic stroke, they have patent foraminal valleys, a connection between the right and left side of their heart. And there is a theory that patients who have cryptogenic stroke, one of the reasons they have that is that there's crossage of the patent foraminal valley with a blood clot from the right side of the heart to the left side, causing a stroke. Traditional therapy has been to use antithrombotic therapy, antiplatelet therapy, anticoagulant therapy, but people have wondered, well, what if we close the hole in the heart? Logic, intuition would say, seems like a good idea. Well, a group of investigators did large-scale randomized trial, and they very simply tested the concept of closing the hole versus not closing the hole. And in the group patients who they didn't close it, they gave standard antithrombotic therapy, including warfarin to some patients. In the group that they did close the hole, they gave antiplatelet therapy for a shortened period of time. No difference in clinical outcomes of recurrent stroke events, recurrent TIAs between the two strategies. So although there was a logic to it, it did not improve clinical outcomes.
So what impact should these results have on clinical practice?
I think there's a couple of things. Let's take the closure one first, because there are people who are closing these around the globe as part of routine clinical practice because they believe that there's value to this. If you're doing it routinely, you probably shouldn't be unless we have more data that suggests that that's the right thing to do. It doesn't mean that ultimately with a different type of device or something that we might not be able to achieve better outcomes by closure, but right now with this particular device does not appear to be any advantage. The second lesson is that as physicians, we like to believe that we understand diseases by understanding the pathophysiology, by understanding our clinical intuition about things. But we need to be reminded, and trials like this do remind us, be careful. Think about what you're doing. Think about whether it's been studied appropriately. And don't be so wedded to your pretest belief that you're not willing to accept that you're in fact wrong.
So those were some negative results we saw in both of those trials. Were there any good positive data we saw in prevention or treatment?
We've seen some terrific data today at the Heart Association meetings. In fact, just before I came here, I came from a session where they presented the results of the partner trial, the quality of life results in the partner trial, which was a trial, as many of the listeners will know, compared transcatheter aortic valve replacement with standard of care for a group of patients who have inoperable aortic stenosis. Those data were published in the New England Journal of Medicine, showed a dramatic mortality effect in favor of the aortic valve replacement. Today they presented for the first time the quality of life data, and it is striking. Not only is there a mortality benefit, a fairly substantial one, but there is a huge quality of life benefit as measured by the Kansas City Cardiomyopathy Questionnaire. So this is really important news that here we have a group of patients critically ill, miserable quality of life with advanced inoperable aortic stenosis. We have a therapy that reduces the risk of dying. We have a therapy that makes people feel better and makes them feel substantially better. The commentator, John Rumsfeld from Colorado, made the comment that on the cardiomyopathy score that they used, the movement that they saw in that score was like moving from a class 4 heart failure patient to a class 1. Dramatic. So that was the best thing I've seen today.
So we have seen some negative data. We've also seen some good positive data.
That's how science is.
Thank you, Dr. Harrington.
Thanks for having me.
For InFocus, I'm Crystal Phend, MedPage Today in Chicago at the AHA meeting.